everyone. Today I'm going to present a tremor case. So this is 76-year-old man with over 20-year history of tremor in his arms, in his head, and also in his voice. So the action tremor in his arms affecting writing and fine motor dexterity. So the stress worsens the tremor, but there are no change with alcohol. He denies a Parkinson's symptom like resting tremors, stiffness, or slowness. He has poor balance with falls. He was treated with ET medication without much benefit. He has a significant family history of tremor in his father and also younger sister. His daughter has premature ovarian failure. He is currently still treated with ET medications. Okay, so we can take a look of the exam. So we don't see resting tremor here. And then for the posture tremor, you can see slight to mild, a flexion extension like proximal arm posture tremor, and also can see a diffuse bradykinesia. And also you can see here, the head tremor, like posture tremor in his head. I can go a little bit faster. And then we can see the on finger to nose, there are slight kinetic tremor and also more intention tremor in both sides. Okay, so then we see again the posture tremor in arm or stress position, also a little bit worse in wind beating position. Then the voice tremor. So his gait is not too bad. So he has a wide, narrow base gait, normal arm swing, a little bit unsteady on turns, and also difficulty doing tandem. So the imaging shows T2 hyperintensity in bilateral middle cerebral peduncle, and also T2 hyperintensity in the splenium or corpus callosum. And also we can see the diffuse cerebral atrophy. So the patient had a genetic testing found to have CGG trinucleotide repeat in the pre-mutation range. So he was diagnosed with Fragile X tremor ataxia syndrome. So FAX test is a neurodegenerative disorder. We think it is a toxic gain of function due to Fragile X mental retardation. One mRNA mediated neurotoxicity from expanded trinucleotide CGG repeat in the pre-mutation range. And it has reduced penetrance, but with increasing age, the penetrance will increase. It's more frequent in older men with onset over 50 years old, but it also can happen in older women, but they have milder symptoms. So the clinical criteria can be divided into 3 levels, depending on the clinical and radiological features. So the major clinical features include intention tremor, cerebellar ataxia. The minor clinical criteria include Parkinsonism, executive dysfunction, and also neuropathy. So the major radiological features include MCP sign and also the splenic corpus callosum white matter lesions. And the minor radiological features include cerebral white matter lesions and also generalized atrophy. So the treatment, we still need to rule out reversible causes, and then we treat patients according to their phenomenology. So if the patient has more essential tremor presentation, we treat for essential tremor. If the patient have more Parkinson presentation we treat for Parkinson. And then deep brain stimulation can be used for refractable tremor. So we don't need to screen everybody with essential tremor or Parkinson symptom for FACS test. So if we see a patient have a combination of tremor, ataxia, and also family history of intellectual disability, autism, or premature ovarian failure, or CGG pre-mutation, where we see atypical imaging findings, we can go ahead to order the genetic testing, so it will be higher to confirm the diagnosis. Okay, so that's my presentation. Thank you for your attention.
Thank you for the case. That's a really, really interesting case. All right, thanks, Clay. So, share. All right, there's our CME code again. So today is the Janice Massey Leaders in Neurology lecture for 2021. Janice Massey is a legend both in our department and around the country. This is just a brief bit of biography on Janice. She went to Abilene Christian, which this year became even more famous because they made it to the NCAA basketball tournament. And I think they won a game. But then went to medical school, started out as a math teacher, then went to medical school. And, you know, she's had a hugely impactful career in neurology and continues to that. She's had 10,000 citations, has been named Physician of the Year by every group she's ever been affiliated with, and has had leadership positions throughout neurology. She remains a very busy and a superb clinician, teacher, and scientist. The lectureship, this is the sixth. Dawn, sorry I didn't bold your name. But Story Landis was our first, Eva Feldman, Louise McCullough, Rebecca Gottesman, Frances Jensen. And now we're really pleased to have Dawn Kleindorfer, and Wayne's going to introduce Dawn.
Thanks, Rich. Good morning, colleague. Today I had a great honor to introduce the annual Massey Lecture speaker, Dr. Dawn Kleindorfer, the neurology chair from University of Michigan, and Rob the Bear professor, endowed chair of neurology. The title talk is Racial and Geographic Disparity in Stroke. As Dr. Janice Massey kind of pointed out just a few minutes ago, it is a major issue and in the South. As Richie pointed out, the Massey Lecture was created to recognize a leader in neurology. Dr. Dawn Kleindorfer is absolutely a leader in the neurology. She's one of the few women neurology chair in the country. She was an executive vice chair of University of Cincinnati before she joined the University of Michigan. She was a co-director for the Cincinnati, North Kentucky stroke team and a stroke division director for almost 1 decade there. He made an important contribution to the stroke epidemiology research. She consistently received funding from NIH, published over 200 manuscripts with an H index of 56. She serves many of the national stroke committees, contributed to many of the position paper and stroke guidelines. But at the same time, I would say, Dawn is also viewed as mentor in the stroke field, which she gave me a lot of good advice during my junior years. She was always very kind, very patient to stroke fellows, junior faculty. We can always see every year during the International Stroke Conference. At the University of Cincinnati, she was also served as executive vice, associate dean of the faculty development, women's initiative there. Over her tenure at the University of Cincinnati, she mentored at least over 2,000 trainees, both at Cincinnati or even folks outside the University of Cincinnati. She was a stroke fellowship director for 13 years. In 2018, she was recognized as stroke research mentor by the American Stroke Association. And most important, she directed the stroke net training program, really boosted research quality. I can go on, but I probably start here, and because I know we all anxious to listen to talk. Again, welcome Dawn Kleindorfer to kick off the May Stroke Month at the Duke.
Thank you, Wayne. What a wonderful and kind introduction. I really appreciate it. And I'm so honored to be here and to honor Janice Massey, somebody that is internationally known, and it's very much of an honor for me to be here. So let me share my screen. Everybody can see that okay?
Yes.
Right.
Yes, we can.
All right, so there are no financial disclosures. So the outline of my talk today is going to be going over racial and geographic disparities in stroke. And specifically, we'll talk about mortality, incidence, changes over time, recurrence, and other things like risk factors and the influence of rurality on some of these geographic differences that we're finding. Some disclaimers. Most of my work has been focused on Black, white, and geographic disparities. Of course, there are many other disparities out there, including gender, social disparities, and they are important. And many times they're intersectional with the racial and geographic disparities, but I'm not really going to talk about those today and try and focus my talk just on race and geography. And most of this work was completed while I was at the University of Cincinnati. I just became the chair at the University of Michigan in May of last year. And so just to let people know, and I'm still the PI on a project, on this project that is run out of the population of Cincinnati. So just to start off, there's some terms here that I think people sometimes get confused about. There is something called stroke mortality, which is just how many people died of stroke. And that usually comes from death certificate data. And what you can see is when you look at over time, over decades, mortality from both heart disease and stroke has been going down over time. And the colored lines, blue is white and white race, and red is Black race. And you can see that in heart disease, men are up here and women are down here. And in stroke, Black men and women are higher than white men and women. Everybody looks like they've been going down. That's great news, right? Well, when you actually look at this a little bit further and break it out, you look at the Black-white ratio, or what is the racial disparity that is going on here? And it turns out that the racial disparity, the ratio between Black and white stroke, is actually getting worse over time instead of better. And so for men, there's a 55% increase in the disparity over time. And for women, there's a 26% increase in the racial disparity between Blacks and whites in stroke mortality. So while, yes, this looks good, and of course we want mortality to be going down, clearly we're not fixing the racial disparities that are going on in stroke. One thing that I think is also very interesting is looking at the age differences in disparity. And so these are the different races across the bottom here: African American, Indian, Asian, Hispanic. And the color bars are the different ages of the patient at the time of their first stroke. And I think what you can appreciate is that there isn't much for age differences in these other races, but in Blacks, they tend to have a much higher stroke incidence in the younger ages. And by the time they get to be elderly, their risk is about the same as it is for whites. So there's an age-race interaction here that is very important. So what is the cause of excess mortality among African Americans? There are several possible explanations. It may be that once they have their stroke, they have more death after they have it. They may have case fatality that's higher. This may be differences in care, or maybe something related to their stroke. They may also have, instead of just death, it may be that they're actually having more strokes And that explains why there is a higher mortality, or it may be a combination of all of the above. So that was when I first started in this in my junior faculty years, this was not really known. And so it was kind of a driving force for me in my career. So this is the Greater Cincinnati, Northern Kentucky. I like to joke, this is my laboratory. I don't have a bench. I have a population of 1.3 million. That is my laboratory. Our study was designed originally by Joseph Broderick. Those of you that are familiar with Dr. Broderick, is internationally known stroke researcher, back in 1988, and has continued every 5 years from that time. I took over the study in 2005 with Dr. Casella. And the study is designed to study these racial differences in stroke. And basically, this is the Cincinnati region. These are the 3 states: Indiana, Ohio, Kentucky, the Ohio River, the circle of the interstates around it, and the green squares are all the hospitals in the region. And so what we're able to do is to get all of the strokes that happen within the population. And it's actually an ideal population for studying this, because it's very representative of the United States population as a whole in terms of the percent Black, age, educational level, median household income. It's very close to the overall population of the US, with the exception that we don't have much Hispanic population. But otherwise, it's a kind of an ideal laboratory to evaluate, especially changes over time, and to evaluate our progress in some of these racial disparities that we've been aware of for a while, and to try and further understand what the issues might be that are causing some of these disparities. In addition to doing the hospitals, though, we also sample outpatient sites, which is really important because there may be differences in race or culture or ethnicity about how they seek and utilize care. And so we also sample all of the local hospital clinics, the coroner's offices for those patients that are found dead in their homes, nursing homes, and physician offices. And we sample all types of stroke: ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and also TIA. And that turns out to be, in a 12-month period, about 4,000 events. To find those 4,000 events, though, we have to screen about 15,000 charts in the medical record. It's a retrospective study. So after the study year has completed, we go back and look at medical records. So here is some of the data. What we were looking here at was the incidence of stroke. And these are the different study periods over time that we've had: 1993, 99, 2005, 2010, and 2015. And these are the incidence rates for all stroke, not including TIA, but ischemic stroke, ICH, and SAH, all subtypes per 100,000. So here you can see that it looks like this is great news. Look, 93 is 230, and 2015 is 189. And then you start breaking it out by subtype. Well, this is the overall trend. Are there differences by what type of stroke there are? And you can see down here, subarachnoid hemorrhage is a very much rarer condition. It's only 10 per 100,000. And really, there's been no significant change in the incidence of subarachnoid hemorrhage over time. ICH is a little bit more frequent, but still pretty rare compared to ischemic stroke. As you all know, ischemic stroke is about 85% of all stroke. Intracerebral hemorrhage is probably 15%, and subarachnoid is about 5%. And we've consistently found those numbers in our population as well. And you can see that there's been a little blips here and there, but there really isn't a consistent trend over time in intracerebral hemorrhage incidence. But in ischemic stroke, we clearly saw that there has been a decrease over time in stroke incidence in ischemic stroke. Again, looks like good news. So then let's look at it by race and see what we can evaluate. This gets a little busy, is why I've got some of this covered up so we can focus on what we're looking at each time. Here are the white population, and here is the Black population, and each of the study periods over time. And what you can see is there is a significant change in the white population, the decrease over time. And this difference, while it looks like a large difference, is actually not significant over time. And as in the overall numbers, what really seems to be driving these decreases over time is white ischemic stroke patients are decreasing over time, and all of the other ischemic stroke subtypes are not. And in fact, I told you I'm not going to talk about gender, but actually it's white men that are decreasing over time. White women and Blacks really were essentially unchanged over time. And this is just to show you that we found this age race interaction in our numbers, just as other people have for decades, and the CDC has published that the age that their first onset of stroke is much, much younger in Blacks compared to whites. This is the hazard ratio for Blacks to whites. So a higher number up here means Blacks have a higher rate of stroke at that age range. By the time you get out to 85, of course, a 1 hazard ratio means there's no difference. There's really no difference among the elderly in Blacks and whites. So a summary of the incidence findings. There really wasn't much of a difference between 2005 and 2010, or 2010 to 2015. Much of that change actually was earlier on, and we didn't really see any decline in Blacks over all study periods, which was really disappointing. The whites had initially gone down pretty dramatically in 2010, and 2015 it stayed the same. We're still seeing this age-race interaction, which is significant. And this has important societal implications. If you are having a particular race or ethnicity that has their strokes younger, that's during the time when they are having their children, contributing as far as to the workforce, and it has different societal implications than if your stroke patients are all in their 60s. And this racial disparity is remaining unchanged or actually even growing over time. So you remember when I said what the possible explanations might be of this stroke mortality difference? It could be they're having more strokes, which we've already seen they are having more strokes, or it could be that they're dying more after their stroke. And so this is the case fatality data. This is a 30-day all-cause case fatality. And what we find is that there really is no difference over time in case fatality. There really has not been much of a change for all subtypes for ischemic stroke or for intracerebral hemorrhage. I do think it's interesting here. Look at this difference in subarachnoid case fatality. There is a dramatic decrease in case fatality for subarachnoid. And if you had to hypothesize why that might be, you could imagine things like neuro ICUs and earlier stabilization of ruptured aneurysms, care provided, vasospasm screening and management. There's a lot of changes that you could imagine might impact the case fatality after they've had their aneurysmal rupture. So then what happens when you look at it by race? And what we're finding is that there is no difference in case fatality between Blacks and whites. And there's no change over time among Blacks and whites, which is interesting. So basically what we're finding is that this stroke mortality racial disparity of more strokes, more Blacks dying from stroke than whites, is pretty much purely related to they're having more strokes to begin with, and not that they're dying more after their strokes. And interestingly, case fatality, despite all of the improvements in our care that we have been working so hard, is really not significantly changing over time, except for subarachnoid hemorrhage, which has significantly decreased. So all of this data that I've been showing you so far is related to their first stroke. One of the interesting ideas, though, is, well, what about recurrent stroke? If they have another stroke, is the racial disparity just as large for recurrence as it is for incidence? So what we first did is to look at just the basic demographics. What is the race disparity for recurrent strokes? And what you see here is that just in the basic demographics, age doesn't seem to matter as much anymore. Age is a huge impact on their first stroke, but age and gender don't really impact recurrence much at all. And it does increase perhaps a little bit when you just look at the demographics. Black race does have a slightly increased risk, But if you then start to think about, well, what about the risk factors and what about the subtypes of stroke, you can actually see that this impact of race on recurrence goes away. And what you see is that actually hypertension, diabetes, current smoker, all of those risk factors increase your risk of a recurrent stroke more than just being Black. And the other thing here is that if you have an initial hemorrhage, you're much more likely to have a recurrent stroke than if you have an ischemic stroke. So what is causing this recurrence? What is causing this excess mortality among concurrents? So the idea that there might be higher prevalence of stroke risk factors such as hypertension and diabetes, or it may be sociodemographic factors among the African Americans. And some of these sociodemographic factors increase poverty and access to care, distrust of the system, structural and individual racism. And so I just wanted to then briefly segue to the REGARD study, because the REGARD study was designed to study both the racial disparity and the geographic disparity. So I'm first going to talk about the racial disparity piece of the REGARD study, and then I'll come back to REGARDS later to talk about the geographic disparities. So to look at this, instead of collecting all the strokes that have happened and making conclusions about a snapshot in time, which is what my study in Cincinnati is about, the REGARD study said, okay, we're going to collect 30,000 people across the United States, and they're going to be half white, half Black, half in the stroke belt, and half not. And we're going to follow them prospectively over time. And so you can see that those two studies are actually pretty complementary in that one gives you information about a lot of strokes at a single point in time. The other gives you information about people as they move forward. You can evaluate for development of stroke risk factors and get an idea of what's happening to them over time. So this study followed this cohort of 30,000 patients. They are now on year 17 or 18. It's been going on for a really long time. They do follow-up phone calls every 6 months. They have in-home visits to gather a lot more information from them, including things like medications and blood pressure readings, but they can only do that every 10 years because you can imagine a cohort of 30,000 people. It's very, very expensive to go out into their homes and do these kinds of interviews. And then there are a huge number of ancillary studies that have been added on to the REGARDS cohort, including many diseases beyond stroke. Once people in cardiology and renal disease and cancer got wind of a cohort of 30,000 people that we're following, they started adding on and trying to follow them for the other diseases as well. So it's really been a tremendous resource for the stroke community, but actually overall health. And this is just showing you the distribution of the participants in the REGARD study. They ended up recruiting 30,239. Red dots are white, blue dots are African American. You can see that there is more African American participants in the South. That's partly intentional because of the geographic distribution. And so what they did here was they looked at this, again, as a hazard ratio. So a hazard ratio of 1 means that there's no difference between Blacks and whites. And what you can see here is that as the age gets older, the risk for Blacks versus whites goes down, just like I've shown you in the CDC data and in our data from Cincinnati. And so what they were trying to do was to understand how much of this disparity is related to things like risk factors and socioeconomic status. And what you can see here, if you adjust for these risk factors and socioeconomic status, then you would expect this line to come all the way down to 1. That if that explained the racial disparity, that there should be no difference between Blacks and whites. And what you see here is that the green line here is related to demographics, and the blue line here is related to risk factors. So you can see that even adjusting for age and socioeconomic status and risk factors, there's still a pretty significant disparity here in the younger age groups between Blacks and whites. So it isn't just that Blacks have more hypertension, and it isn't just that they have more sociodemographic challenges that we can measure. Of course, there are many socioeconomic factors that you aren't able to measure. And these risk factor and socioeconomic statuses really did not change this racial disparity very much over time. So just some comments about risk factors. We all talk about risk factors like having hypertension is yes or no. And we put it into our models and we pat ourselves on the back and say, well, we looked at hypertension and it really didn't answer the question. But I think all of you as physicians know when you take care of your patients that hypertension is not just a yes, no. It has to do with many factors. Some of them you will never be able to get the answers to. How long have they had hypertension? How much did they seek care for their hypertension? It may be that they're seeing their doctor for the first time in 20 years and they get diagnosed with hypertension during that visit and they've had it for a really long time. Or they may be seeking care regularly and get it diagnosed very early in the disease course. Also, we know that there are racial differences in most of these risk factors in the severity at the time of diagnosis and the refractoriness to standard medications among Blacks compared to whites and among other race ethnicities. We know that there are racial differences in the medications that different races respond to. For example, African Americans don't tend to respond to ACE inhibitors, and yet we see it all the time of patients who don't have another reason to be on ACE inhibitors being treated first line with an ACE inhibitor for their blood pressure. And then there are some of these social factors that I was talking about, things like medical compliance, health literacy, and then there's the idea of synergy. Is just hypertension and diabetes, when you have them together, the same as adding the two risks, or is it that it's exponentially, that this combination of the two is worse than just having hypertension by itself? And finally, to talk about the BASIC project, just to take a little detour here about Mexican Americans. The BASIC project is actually run by Devin Brown and Louis Morgenstern, who are at the University of Michigan, where I am now. And it's basically run out of Corpus Christi, which is a unique city in that it has a large population of Mexican Americans and non-Hispanic whites. And very little, before they had started this project, very little was known about stroke in Mexican Americans. And there was a need for some basic epidemiology information on the stroke burden in Mexican Americans. Their study is set up as 7 hospitals with 11 neurologists with active surveillance, meaning that they are screening admission records prospectively, also taking random samples of nursing homes. They're doing passive surveillance using hospital discharge codes as well. And what they're seeing is that there was some decrease in Hispanic stroke incidence over time, but that this racial disparity was persistent, as we saw with Blacks. There used to be a survival advantage that Mexican Americans had a lower case fatality over time, but that has now disappeared, and their case fatality is pretty much identical between Hispanics and non-Hispanic whites. So that was a very high-level overview of racial disparities, mostly in Blacks, but a little bit in Mexican Americans. Now I thought I would shift to geographic disparities in stroke and talk a little bit more about that. First of all, this has been a very US-centric presentation. There are geographic disparities across the world, and when you look at some of the differences, they are really quite striking. If you look at China and some of the other countries in the Asian populations, there's a huge difference in the type of stroke that's most prevalent. Hemorrhage is much more common in the Asian populations. And you can see some parts of Africa have very high stroke mortality and stroke incidence as well, some of the third world countries especially. But I am going to mostly focus on the United States because that's where most of my work has been centered. This is one of my favorite slides. This is really old data, but I think it's really interesting if you look at the difference between stroke mortality rates and ischemic heart disease mortality rates by state. If you would think that risk factors are the same for heart disease and stroke, then their stroke mortality and their heart disease mortality should be about the same. And what you find is that that's not actually the case. And I don't think that we really understand why that is. It's not related to death certificate data. But if you look, for instance, at the state of New York, at the time of this data, which I think was in 2005, New York had the highest, number one ranked ischemic heart disease rate and the number 50th stroke disease rate. Isn't that unusual? I don't think that we yet understand some of these state-based differences. It's death certificate data. There are lots of problems with death certificate data, but it's really an interesting geographic disparity that I think is yet unexplained. Within the Cincinnati population, just to go back a little bit to the Cincinnati study that I'm the PI of, we've even done micro-targeting or looking at small areas of geographic differences within Cincinnati. These are census tracts. So they're divided up by the census. They usually have about 4,000 people within them. They tend to be chosen to represent geographic and demographic similarities. And you can see that there are hotspots for stroke incidence, even within just this population of 1.3 million. And that these are very similar every time we do the study. There's this strange pocket of rural high incidence stroke out here, down in Kentucky here, downtown. There are areas that are bad for stroke incidence, but there are also areas that are quite good. And that we have looked at to try and figure out what that might be. And then when you look at the United States as a whole, this again is the stroke belt idea that the South has significantly higher rates of stroke mortality compared to the North. And even within the South, you can see that there are counties. This is county-based data here. And there are counties that are very good right next to counties that are very bad. And so when you're looking at the discrepancy, you can see that it isn't just a homogeneous increase of stroke mortality. There are geographic differences even within county by county in the South. I'm going to skip that. And so when we're looking at stroke mortality and the stroke belt, there are lots of people that say, well, obviously it's just that there are more Blacks in the South. Well, the stroke belt exists in both Blacks and whites. It actually exists in adults and children. Even stroke in children is higher in the South when compared to the North. People have thought it must be something with the coding of death certificates. There must be some difference related to socioeconomic status. It must be case fatality, quality of care, prevalence of risk factors. Many of these on this side of the graph have been investigated and have not been shown to be causal. People are then starting to look at things like infection rates, genetic factors, environmental exposures. One of the sub-studies that I think is really cool with the REGARD study is they actually partnered with NASA and used their terabytes worth of data of environmental exposures. They have looked at toxins in the soil, they've looked at water quality, air quality, and so far, none of that is really explaining the stroke belt either. So it remains unexplained as to why that stroke belt exists. One thing that I am particularly interested in is the rural-urban disparity, in that, and this is interesting because there's a big difference between rurality and race in the North versus the South. In the South, there are many more rural African Americans. In the North, African Americans are largely concentrated in larger cities. And so when you're looking at what is the rural-urban disparity, there's a rural-urban race interaction when you're trying to figure out what the differences might be. But what we have found over and over again is that rural regions in the US, regardless of the stroke belt or not, have a higher stroke incidence and a similar case fatality to those in more urban areas. And then just to show you some of the prevalence of risk factors, I think these maps are super cool. Looking at differences in geographic regions for risk factors by race, you can see that for hypertension in whites, it tends to be very centered in the South. And for Blacks, it's centered in the South, but maybe not exactly in the same area. Whites have much more of a lower region out in the Pacific Northwest, and you don't see that as much in the Blacks. And then diabetes in whites tends to be centered almost in the same area as hypertension, but in Blacks, it really is much less until you get down to the tip of Florida. So why is that? I don't think that we have an answer. And what I didn't include here, but what I think is really interesting is this stroke belt. Let me see if I can go back to that picture of the stroke belt. Here, it's hard to appreciate, but there is a little bit of a clearing here in the stroke incidence for stroke. This is actually what they call the coronary valley. And so if you look at a map of ischemic heart disease, there is a high prevalence of coronary disease in this area where there's a relative clearing of stroke. So it's really interesting to look at things like risk factors, other diseases that should have the same risk factors, and find these geographic disparities that are yet unexplained. Going further into the smooth prevalence, whites tend to be focused actually more in the Missouri region, and Blacks tend to be highest in the very north. And I don't know that I understand why that is. And then just a somewhat depressing view of the change over time in obesity. This is from the BRFSS data. If you look back at just 1990, the highest prevalence obesity by state was at the 10 to 14%. And if you go to 2010, many states are over 30%. And this trend has continued onward. I'm going to skip that. So in summary, overall, racial disparities in stroke death have been known about for decades, and they are profound. We believe that they are driven by stroke incidence, meaning they're having more strokes rather than case fatality, because they're dying at about the same rates between Blacks and whites after they have their event. Once you have your stroke, though, recurrent events don't seem to have the same racial differences. There are very important age-race interactions, and that Blacks tend to have their strokes younger. And trends over time in both Blacks and Mexican Americans do not show improvement in any racial disparities that we have found. To summarize the geographic disparities exist at every level. The stroke belt is likely related to increased stroke incidence and rurality. Blacks are impacted more by the stroke belt than whites, but do not explain the stroke belt. And the underlying etiology is likely multifactorial, including things like socioeconomic status, lifestyle, behavioral factors, diet, and other factors. So with that, I'd like to say thank you. A special thank you to George, Howard, and Linda Elizabeth for use of some of their slides and descriptions of their studies. And because I just wanted to end, have been passionate about stroke awareness for many years, and this is May Stroke Awareness Month. So I would encourage you all to try and teach your patients, all of your patients. We know that the neurology patient population tends to be older and has a higher risk of stroke. So please teach them fast. And I'll tell you how I teach my patients fast, which is, I say, for a brain attack, think fast. FAST, face, arm, speech, time. Can you say that back to me? And I asked, that's right. Thank you, Wayne. I asked them to say face, arm, speech, time back to me. And then I say face is a droopy face on one side. Arm is you ask them to hold up their arms and see if an arm falls down. Speech is slurred speech or trouble talking. And time is there because it's time to call 911. And including both the symptoms and a plan of action if they see those symptoms is really important, because there's a disconnect in people's knowledge about stroke, and that they tend to either know the risk factors or they know to call 911 if it's a stroke, but they don't know what a stroke is. So you really have to combine the messaging of warning signs and a plan of action. And whenever you're teaching about stroke, you're using words at about the 3rd grade reading level. People tend to use things like ischemic stroke and hypertension and all of these terms that patients may not understand. And getting them to tell it back to you and confirm their knowledge and understanding is really important. So for all of you, go out there and teach people about stroke, and I would be glad to take any questions. Thank you.
Thank you, Dawn. So if anyone has any questions, just either put your name or question in the chat session and we'll call on you. So Dawn, so why hasn't the use of TPA made noticeable changes in, minority populations?
That is a great question. And that is probably one of my other passions in stroke research over the years. I remember I asked a question as a fellow to Joe Broderick. So how many people actually get TPA in the United States? And the answer was a lot. And nobody had really studied it. And then when we started looking at it, there weren't very many people getting TPA. This was early on, maybe it was utilization or acceptance of the therapy. But my question was, how many people actually are eligible for TPA? And I asked people, kind of stroke docs, and I asked this of my residents all the time. I think they all learned the answer from each other to answer the question right. But I usually would ask, how many people in a population, a ischemic stroke population, do you think are eligible for TPA? And the answers I would get would be 50%, 75%. And the answer is about 8% or maybe 11%. So it is not very many patients were eligible for IV TPA. And of course, TPA is not going to change. So TPA might impact case fatality, right? So if you took a stroke that happened and made it less severe, then they may be less likely to die, but it's not going to change their incidence. And the incidence is where we're seeing all of this racial disparity over time. So TPA and acute treatments are great. They're not going to change the public health problem of racial disparities.
Thank you. Wayne?
Thanks, Don, for a great comprehensive, in-depth, and a description of the racial and geographic disparity in stroke. I would say our health policy in the past few decades, it is somewhat working, because death rates are getting better across the group. But the issue is really persistent racial disparity and regional disparity. If you were the health policy maker, how would you do different in the next few decades to address this issue?
That's a great question. And I think this is kind of heresy in the stroke realm, but I feel like there's been a lot of emphasis on TPA and embolectomy, and finding those 2 patients that present at 23 hours and whether they might be qualifying for embolectomy. And we're not talking about primary prevention and working with our primary care colleagues to identify strategies that work in different populations, right? The idea that their primary care doctor just needs to talk to them about their blood pressure probably does not work among many African-American populations. And so trying to identify community champions, do more community-based participatory research to find methods to prevent the risk factors, which then downstream lead to stroke. I mean, we're coming at this, I feel, from the neurology perspective was, oops, they've had a stroke, now what? And wouldn't it be great if we focused on preventing the stroke in the first place? So, the secondary prevention guidelines will be coming out soon. And I've been chairing that, and it's really been an eye-opening experience, and just thinking about all the different things that we could be doing for prevention of stroke that may not be as much of an emphasis, certainly not for neurologists. And I think we need to partner more with our primary care and our communities to prevent the stroke. That would be my 100,000-foot view. That doesn't really tell you how I would change policy, but I think we need to shift our focus as neurologists away from, we have great treatments, and yes, I will continue to take stroke call and do embolectomy, you know, and recommend IVTPA, but I think we need to focus on prevention.
Cheryl, you have a question?
Dr. Kleindorfer, thank you for an excellent talk. Cheryl Chang. I just recently relocated from Hawaii, but one of the things I'd noticed when I started doing stroke there 20 years ago was these disparities that you're talking about. And actually, we created our state Get With The Guidelines to look at the different even subgroups of, we found that the Filipino population had a higher death rate, that the Native Hawaiian had a higher death rate than, say, the Chinese or others. I'm curious whether you've thought about, because that's a very small, you know, population of 1.4 million. Have you thought about looking with your, you know, great tools that you have about a small, like, test population like that, and kind of looked at something like that now that we have tools to explore that population?
So I'm not sure, I'm going to restate your question to make sure I understand it. I think you're asking about Get With The Guidelines and why.
Yeah. So there's a smaller, you know, so there's obviously health disparities, and there's ethnicity, there's maybe people that have socioeconomic issues. And I'm wondering, you're looking at a very, very large, you know, the national, and then you have maybe a smaller test population. What are your thoughts about looking at a smaller population like that, different health disparities in ethnicity, using the tools of Get With The Guideline to look at that? How would you best explore that?
Right. And so what I didn't talk about was anything with Get With The Guidelines. And that was sort of intentional. Get With The Guidelines is a quality improvement registry. It wasn't designed for epidemiology. It has, it's really great for hospitals to monitor and track the quality of care that they're providing. It is not so great for looking at epidemiology or health disparities. It has huge numbers. And so everybody is very wowed by using Get With The Guidelines. And I absolutely think it has value. I also think it's complementary to population-based research, which will include things like out-of-hospital strokes, strokes that happen when they're in the hospital, which are all excluded from Get With The Guidelines. And looking at changes over time. So I absolutely think it's complementary for these groups that, you know, obviously 1.3 million is actually probably the largest stroke incidence study besides the REGARD study out there. As far as a population-based study, Get With The Guidelines has massive numbers. And so you could look at these smaller subgroups and slice and dice the data up that way. As long as people understand the limitations of the QI database, I think it has a lot of potential.
Okay, thank you very much.
Armin?
Hi, thank you so much for that talk. One of the things that I don't see very often brought up in risk factors, and yet the literature, as I read it, is growing increasingly strong in this area, is the role of stress, whether it's socioeconomic stress, cultural stress, work stress. We know that it impacts cortisol, it impacts vascular anatomy. And when I talk to many African-American patients, they'll tell me, Doc, do you think stress could have caused my stroke? And in the past, the typical answer has been, well, yeah, stress leads to more blood pressure, but independent of its effects on blood pressure or on bad eating habits or on smoking, it seems that stress in and of itself, through its immune endocrine effects, seems to be very damaging to the vascular system. Have people looked at the different levels of stress between different socioeconomic and demographic groups, and what is causing that stress so we can actually address it as one of the disparities?
Yeah, that's a super interesting question. And I think there's two different types of stress that people have investigated. One is something really bad happens at the time right before I have my stroke. So I think we've all probably seen this. If you do stroke long enough, somebody has a stroke at their husband's funeral. Or there's some trigger event that everybody says, oh, it must be related. And then the other type of stress that people talk about is this chronic stress. And there's clear literature that race ethnic minorities have higher rates of chronic stress. related to life events, related to structural or individual racism, related to any number of other issues. And so the problem is trying to quantify that stress and understanding how that might be impacting stroke incidence. We tried it within the REGARD study. We tried to do a life events stress scale where you ask them, have you gotten married? Have you gotten divorced? Have you moved? Have you lost your job? All these kinds of chronic stress events that might have happened to you in the last year, and gives them a number, a score, and then compared that to their risk of stroke happening in the future. It's a really difficult thing to study. They didn't really find much in the way of relationships to stroke incidence, and certainly not by race in the REGARD study. But it's a smaller number of events in REGARDS. You know, they have massive numbers of people that you're following, but the number of stroke events that happen every year are smaller, is that their denominator is 30,000. And that really takes a prospective questionnaire that people are answering. And of course, people that die, you have a survival bias. So the people that have the most severe strokes won't be able to answer those questions about their stress levels before. So it's an interesting idea, very difficult to study.
All right, we have time for one last question. Shri?
Hi, this is Shri. I'm one of the stroke neurologists and a neurointensivist. So my question is that different social groups tend to access healthcare differently. Like we have seen this number of times again and again that people who are African American or Black will go to different providers or will go to different hospitals when they have stroke, or they will have different primary care providers. How does this impact in how their risk factors are managed, or how they get secondary stroke prevention or stroke care?
Yeah, there's a growing literature about race ethnic minorities and physicians. And interestingly, the race ethnicity of their physician matters. And that if their race ethnicity matched to their patients, they have better compliance, better control of their risk factors over time. So in the outpatient setting, there are clearly differences in the management and control of risk factors by race ethnicity. You know, the hospital issue is particularly interesting to me because in the North, like I said, most of the African Americans are in cities. And in fact, they tend to be in the downtown areas, which, by the way, is right next to the academic centers. So African Americans tend to be cared for by the stroke experts. And in the rural areas, that tends to be much more of the white population. In the South, it's a little bit more mixed in that there will be Blacks being cared for in rural hospitals and in academic centers. And so there's this weird geography type of medical center that and so whenever you're doing hospital-based analyses, you should always be including the type of academic center that you're dealing with, if it's academic or community-based. So absolutely agree. Is there a clear answer to any of that? Not yet.
Okay, thank you.
Thank you so much, Don. It was an honor. It's a great talk, and best wishes. I mean, you arrived in Michigan in the middle of a pandemic. It can only get better from there.
Well, thank you, everyone. It's been really great, and I appreciate the invitation.
Thanks, Don. Mhm.